This comes up not frequently in clinic. So for those of you that come to my clinic, we talk to patients a lot about chemotherapy. You might say, well, why is a urologist talking about chemotherapy? It's because we're really the gateway to chemotherapy for most patients with muscle invasive bladder cancer. And it's important that we're knowledgeable about which patients are appropriate for a perioperative chemotherapy, as well as the side effects and the regimen, because a lot of times patients will ask me, well, what do you mean? What is 4 cycles? What does that look like? How does that impact my livelihood? So it also shows up a lot on written examinations. So I know the in-service is coming up in the next few months, and it'll show up on other written examinations. So this is really an important topic, and one that I think every urologist should be informed about. So we're going to talk about, really, this is broken up into 3 different sections. The first section, we're going to talk about neoadjuvant chemotherapy. The second section, we'll get into adjuvant therapy. And the last section, which probably, I was thinking about putting it first because it's probably the most exciting section, but we'll leave it at the end as sort of we'll end strong, is what's hot in systemic therapies. There's been a lot of really exciting discoveries in the past 5 years, and we've really started to move the needle. For about 20 years, we only had one mainstay treatment for chemotherapy for bladder cancer, and that was cisplatin-based chemo. And we now have 5 additional treatment options. So we've really started to move the needle. I think it's a really exciting time to be taking care of patients with bladder cancer. Maybe not as exciting for the patients, but that have it, but certainly for us, we have more options, more tools in our toolbox. So for this first section, we're going to really dive into neoadjuvant chemotherapy. And really the first question you have to ask is, well, why? Can't surgery just fix all my patients or get rid of all their cancer? And this is an old historic study, but it really is, it shows why perioperative chemotherapy is important for these patients. And these are patients that all underwent radical cystectomy, 507 patients, and they were followed for 45 months, and none of them received chemotherapy. So that's the key. So without chemotherapy, you can see this top curve, the PT1s and 2s, they actually did pretty well, but about 25% of patients did have a recurrence. And then the T3s and the T4s, once again, none of these patients received chemotherapy, had a much higher rate of recurrence, which makes sense. Their disease was more advanced. And you see with lymph node positive disease, that goes up even higher. So really, there is a risk of metastasis, even in patients that have organ-confined disease, because within that muscularis propria layer, that's where the lymphatics and the blood supply exists. So that's where metastasis can occur. I've even seen some patients that were stage T1 that developed metastatic disease. So it can happen even in earlier stage disease. And the median time to recurrence for these patients is usually within 1 year. So that's the rationale for neoadjuvant chemotherapy and for adjuvant chemotherapy if they didn't receive it in the neoadjuvant setting. Now I'm going to need, I don't know what happened, some of my slides I think didn't quite transfer, but I'm going to need some help from the audience. So from the residents, mostly. I'm not going to call on, Zoe's hiding behind Dr. Williams. So, but there are some pros and cons to everything we do. We have to have this discussion with patients, and it's important that we understand what are some of the pros and cons of neoadjuvant chemotherapy. So I'm gonna start with Ali. So pros of neoadjuvant chemotherapy. Pathologic downstaging, good. Anybody else want to chime in? What do you think, Andrew? Decreased risk of recurrence. Excellent. Excellent. Anything else? Anybody else have any ideas? Some of the advantages of giving it in the upfront setting? Bingo. Thank you from our PEDS team, Dr. Ebert. Well done. Patients are in their best shape, so they can tolerate more prior to cystectomy. Yeah, so there's actually some of the best, really the best data for perioperative chemotherapy is in the neoadjuvant setting, and there's been a clear survival benefit. Patients that I think to Ebert's point are more likely to receive it prior to surgery. There was some concern that it might lead to more complications with cystectomy. That actually has not been shown to be true in any study that I'm aware of, and they're at their best. So thank you for participating. There'll be some more opportunity. Oh, I'm missing a few bullet points here. So what are some of the cons? Dr. Davidson, you look like you have an idea. Yeah. So just the side effects of chemotherapy. Yeah.
Hearing issue.
Mm-hmm. Yeah, so that's a good point. So I think Emily touched on a lot of things. So common side effects of cisplatin-based chemotherapy are a hearing loss, peripheral neuropathy. So if somebody is a diabetic and they already have peripheral neuropathy, a lot of our patients have hearing loss. So cisplatin is ototoxic, so they can have worsening of their hearing function. So yeah, that's definitely any other cons that some people can think of. There's a risk of overtreatment. So not all patients benefit from chemotherapy. There are patients that can be cured with surgery alone. It's hard to know which ones, it's hard to pick those out. So giving neoadjuvant tends to be kind of a shotgun approach in the sense that we're just gonna treat everybody knowing that some patients may not need chemotherapy. Patients sometimes have a reluctance to delay surgery. They think, well, chemotherapy takes 12 weeks, so I'm going to have to wait 12 weeks to have my bladder out. So that could be a concern for some patients, although I try to reassure them that by getting chemotherapy, that prevents the cancer in the bladder from progressing. And about 5% of patients actually blow through chemotherapy and tend to be non-responsive, platinum non-responders. So those are some of the main cons. So where's the data? You always should ask yourself, what data do we have in support of this approach? And this was a pretty famous study published now 20 years ago, SWOG 8710. And it was a randomized phase 3 clinical trial, 317 patients. Started enrollment before some of you were likely born, and it enrolled patients with muscle-invasive bladder cancer that was localized. And the patients were randomized to cystectomy versus chemotherapy, cisplatin-based chemotherapy, MVAC, methotrexate, vincristine, adriamycin, and cisplatin. That was the chemotherapy regimen, and patients were followed for up to 8.7 years. And you can tell pretty clearly on this Kaplan-Meier curve, this top curve here is the MVAC group. They separate early, they stay separated all the way out, and it was seen as an advantage. If you look at the 5-year survival for MVAC was 57%, whereas for cystectomy it was 43%. This is overall survival. And then if you look at it, so the risk of death was ultimately reduced by 33% in the MVAC group. There was no difference or no deaths from MVAC or differences in complications between patients that received MVAC or underwent upfront cystectomy. And there were equal rates of proceeding to cystectomy in each group. So that looks at sort of the concept of contamination in a randomized trial is, did you get the actual treatment? And it was relatively balanced. This was actually this was figure 2 from that paper. And the other really astounding thing was the P0 rate. So pathologist looks at the bladder at the time of cystectomy and they don't find any cancer. And you might say, well, geez, why did you take out the bladder? Well, those bladders are often, probably predestined to develop additional tumors in the future. So I think there are some additional studies going on right now to see if there are some bladders that can be kept after undergoing chemotherapy, but right now that's considered experimental. But the P0 rate was much higher in the MVAC group. It was 38% versus in the cystectomy group at 15%. And you can see on these Kaplan-Meier curves, the patients that were T0 ultimately did the best. So that's actually a really good marker of long-term durable survival is P0 rates, PT0 rates. Now, the trial, as with all trials, does have some limitations. The pelvic lymph node dissection was not standardized. This was done at, I think, 80 some institutions. So you can imagine 80 different surgeons doing different things. That was one of the critiques. There wasn't really good quality control to know, what the operation, was the operation the same at all these institutions. It took a long time to recruit, over a decade, and things certainly change quickly in medicine and healthcare over that period of time. And then, some people will point to the absolute benefit being modest. 14% from this study. Other studies have showed a benefit of about 5 to 10% in survival. And that it's not a huge benefit, but there's other benefits. I think delaying recurrence, delaying time to metastasis has also been shown. And that sort of gets to the point of, potentially overtreatment. Since SWOG 8710, there's been multiple other studies, clinical trials. They've all been lumped together in a meta-analysis. So 3,000 patients, 11 different trials, all in the meta-analysis showed similar findings, that overall survival benefit and a 5% absolute survival benefit at 5 years. And here's the table from, if you look at all trials, the hazard ratio is 0.89, disease-free survival 0.81. So there definitely is a signal there for patients to receive neoadjuvant chemotherapy. Here's the neoadjuvant chemotherapy Kaplan-Meier curve. And once again, you can see that neoadjuvant chemotherapy outperforms cystectomy alone. Now, despite all this data, there's been relatively poor adoption of neoadjuvant chemotherapy for several reasons. Concerns about delaying cystectomy, toxicity concerns, as Emily brought up. The other side effect of cisplatin is it's nephrotoxic. So many of our patients come in with borderline renal function. This also tends to be a really aging comorbid population. So trying to get them through a cisplatin-based chemotherapy regimen can be quite challenging. And then the issues with the SWOG study, I think, mentioned, as I alluded to, led to some of the poor adoption. I think that's improved over the past decade, but it's still not probably where it could be. Getting back to the renal function issue, this was a nice study that showed the proportion of patients that were deemed ineligible based on their creatinine clearance using the Cockcroft-Gault formula by age. So as your age was going up, for instance, octogenarians, 68% would be ineligible based on their GFR. So it's very difficult to get chemotherapy in older patients. And if you look at the different formulas, so there's different ways of calculating the GFR. It really didn't seem to make much of a difference, but each of these formulas showed that there's a significant percentage of patients that would be ineligible based on their renal function. So I think that's still an ongoing issue with cisplatin-based chemotherapy regimens. There's ways around that. Medical oncologists can sometimes reduce the dose or do what's called split dosing, and that can sometimes be beneficial. But even we don't have as good a data for reduced dose or split dose, so there's some uncertainty as far as the efficacy goes when you start messing with the dose of the chemotherapy. So you're probably saying, well, that's really old. That's great and all, but the SWOG trial, that's now 20 years old. Is there any newer data and for neoadjuvant chemotherapy? And if in the one trial that you should really know about in this space is called the VESPER trial. Because as you probably noticed with the SWOG trial, they used a regimen called MVAC, and most of our patients nowadays get gemcitabine and cisplatin because it's a little bit better tolerated than dose dense than MVAC. Um, and but we don't really know if one is better than the other. So that's where the VESPER trial was born out of. And this was a randomized phase 3 trial, and it randomized patients to 6 cycles of dose-dense MVAC. So dose-dense, just when you see that little DD in front of MVAC, it just signifies a different dosing regimen that the medical oncologists use. It actually gets patients through chemotherapy a bit faster than with the standard MVAC. So it was 6 cycles of dose-dense MVAC versus 4 cycles of gemcitabine and cisplatin. Primary endpoint was progression-free survival, and secondary endpoints were P0 rates and toxicity. This was just published in European Urology 3 years ago. There's ongoing data collection and publications coming out of this trial. The first thing you might say, well, is dose-dense MVAC, that's got to be much more toxic than GemCis. That's why we usually use GemCis. But if you look at the hematologic toxicities reported for dose-dense MVAC, that was much higher rates of anemia, 22% versus 8%. But neutropenia, febrile neutropenia, thrombocytopenia was essentially equivalent. And then the non-hematologic toxicities, dose-dense MVAC saw more nausea, vomiting, at 10% versus 3%. These are greater than 3 toxicities, so more significant ones. More asthenia, which basically is, I think of that as like fatigue, really bad fatigue. So 14% in the MVAC and 4% in GemCis, and then everything else was fairly equal. So definitely a little bit more toxic, but not extravagantly more toxic than the GemCis regimen. And then looking at the pathologic responses, so the T0 rate, if you look at that between the two groups, it was 42% in the dose-dense MVAC versus 36% in the GemCis, and that was statistically significant. And then non-muscle invasive pathology was higher in the dose-dense MVAC. This is pathologic staging. And then the dose-dense MVAC also had lower rates of more advanced disease. So looking at the pathologic outcomes, there was a benefit towards dose-dense MVAC in the VESPER trial. So what are the take-homes for neoadjuvant? Number one, it should be offered to almost all patients with muscle-invasive bladder cancer. And these are patients that are coming to see us in the clinic. So we're the ones that need to start the conversation with our patients. The onus is really on us to have that conversation. We should consider dose-dense MVAC in the quote-unquote healthier patients with bladder cancer. Not too many of those exist, but it's certainly something to consider. I've used it in some of my younger, healthier patients. Obviously, this is a discussion that the medical oncologist will have with patients. And then we talked about some of the common side effects. So that's something to be aware of and oftentimes shows up on tests. So the neuropathy, the renal function issue, the hearing loss issue, those are all issues that we need to be aware of. All right, shifting gears now to part 2, which is adjuvant chemotherapy. All right, so what are some of the advantages of adjuvant chemotherapy? Anybody, Ali, do you want to kick us off here? Future urologic oncologist. I got to start with. Okay. There's some data to show that it helps to reduce the risk of recurrence. I agree. It also helps to, avoid the overtreatment issue I talked about, because when if you wait till after surgery, you have the pathology. You know what their pathology is. You have a final pathologic stage. It can be useful in symptomatic patients. So if you've got a patient that is having a lot of symptoms from their primary, neoadjuvant chemotherapy likely isn't going to make their hematuria better. It's likely not going to make their frequency and urgency better. So if they're highly symptomatic, it may be better to consider the adjuvant route. And it can also help to potentially better select patients for chemotherapy. What about some of the cons? Andrew? So it can delay the time to chemo? Or okay, yeah. So you have a cystectomy, they have complications, which we know is not infrequent, and then it might be you can't give chemo until they're fully recovered from surgery. I think that's what you were trying to say. Also, the survival benefit is not as clearly established. The data for adjuvant chemotherapy is not as strong. It was harder to accrue to those trials. And patients are, people have showed this pretty eloquently that they're less likely to get chemotherapy after cystectomy. And that's probably just from complications, longer hospitalization, longer recovery time. All right, so what about the data? So where's the data? There were some adjuvant trials that were ongoing when SWOG 8710 was taking place. And it showed that that you could enroll patients to the trial, but it was very difficult to accrue. They were also using, suboptimal chemotherapy regimens that were not cisplatin based. They were underpowered. There's a lot of methodological flaws. So the adjuvant trials in the 80s and 90s were really not very successful. There were 3 recent trials, 2010, 2012, 2015, that also had issues with accrual and closed early. So we don't have really good data from the adjuvant trials, but we do have observational data, and observational data can be really useful when it's impractical to do a randomized controlled trial. Randomized controlled trials are certainly the preferred approach, but they're expensive, can be very difficult to accrue patients to. I mean, that's just the reality of doing these trials. So we have a really good observational data. This is out of the National Cancer Database. And Matt Galsky, who's a medical oncologist, was comparing the effectiveness of adjuvant chemo versus observation in patients with adverse pathologic features. So these are patients that were pathologic T3, T4, or node positive, patients that would likely benefit from adjuvant therapy. And they looked at overall survival and did propensity score adjustments to try to adjust for any confounding and any bias. And they excluded patients if chemotherapy was not recommended due to their comorbidity. So that they were trying to adjust and control for all the problems you have with observational data sets, which I think they did a pretty valiant effort of. And if you look here, the adjuvant chemotherapy versus the observation group, there's a clear survival benefit. Hazard ratio is 0.61. They included over 5,000 patients, of which 23% received adjuvant therapy. Now, there is some really interesting data. This is another trial that I would sort of look up, and it would be a good one for a journal club potentially, looking at adjuvant nivolumab, which is an immunotherapy PD-L1 family drug. So this is a really, really good trial, a phase 3 clinical trial. It's published in the New England Journal of Medicine 3 years ago. And it included patients that were pathologic T3 or T4 or node positive, or if they received neoadjuvant chemotherapy, if they were YPT2 to YPT4. So that means they had that little Y for the residents. If you're not familiar with that little Y, that means that they had neoadjuvant therapy. You'll see that sometimes in my notes. So they had neoadjuvant therapy. So if they were YPT2 to 4 or node positive, so adverse pathologic features after neoadjuvant chemo, they were eligible and they were randomized to nivolumab or placebo. So it was a placebo-controlled trial for 1 year. Primary endpoint, disease-free survival. And that was, they were looking at local recurrence in the upper tracts, outside the urothelial tract, distant recurrence, and then also death from any cause. And we have our Kaplan-Meier curve here showing this is our disease-free survival curve, so the primary endpoint. And you can see that the curves separate pretty much right at the 3-month point in favor of nivolumab. Disease-free survival at 6 months was 75% in the nivolumab group and 60% in the placebo group, and hazard ratio is 0.7. So positive trial in favor of adjuvant nivolumab, and it had a lot of strengths. It was very quick to accrue. As I mentioned previously, adjuvant trials in the past very difficult to accrue. Perhaps this was faster, maybe sponsored by industry, has something to do with that. But either way, they did a nice job accruing, had a lot of sites to add to the diversity of the trial, 29 different countries. Some of the weaknesses, it was a fairly heterogeneous population, very little racial diversity, only 5 Black race patients in the trial. And it also included some patients with upper tract disease that had primary upper tract urothelial, which we think behaves fairly similar to lower tract. So I think that's a minor point, but certainly a concern. And 43% had prior neoadjuvant chemo. So it is a little bit of a muddy trial. And then the sample size was based on 410 events, and they only had 374 in the trial. So perhaps it was also maybe a little bit underpowered, but they were able to achieve their primary endpoint. So overall, I would say for adjuvant therapy, it should be offered for patients that have unfavorable pathology, whether they had neoadjuvant chemotherapy or not. With this new data from New England Journal of Medicine, you should consider immunotherapy, especially if they've had chemotherapy. If they're chemotherapy naive, I think our medical oncology group probably would consider chemotherapy, but some of it's based on their performance status as well. I think immunotherapy tends to be a little bit better tolerated. We didn't talk about some of the common side effects, but pretty much any itis you can think of occurs with these agents, nivolumab, pembrolizumab, avelumab. So we've seen patients with colitis, like really bad colitis, pneumonitis, so it looks like pneumonia. We've seen patients with myocarditis. We've seen patients with adrenal insufficiency because of their adrenal gland basically gets inflamed, and they have to go on chronic hydrocortisone and fludrocortisone. We've seen patients with pancreatitis. So these itises are not arthritis. We had a patient recently who we did a cystectomy on that was having an arthritis flare that was likely related to the immunotherapy he had received. So these side effects are also not insignificant, but should be aware of those. All right, so for the last 10 minutes, we're going to get into what's really hot in systemic therapy. And the first thing is, and many of you maybe have heard of this, is EV Pembro, or enfortumab vedotin and pembrolizumab. This is really the hottest combination therapy that we're using for patients with bladder cancer. And enfortumab vedotin, which I will just call EV, is an antibody drug conjugate. And this little picture here shows it binding to the antigen, which is Nectin-4. Nectin-4 is highly expressed on epithelial cells. And this is it's linked to these microtubule disrupting agents. So it binds to the antigen, it gets internalized, traffics to the lysosome, then that microtubule disrupting agent's released, and the cell goes into apoptotic state. So it was really an interesting antibody drug conjugate, and the trial to know, and it was subsequently presented at ESMO. And when this was presented, it received a huge standing ovation from the crowd. I mean, people were I think, crying in the audience because this was like so exciting. So as a patient, the patient population was previously untreated, and this was a metastatic cohort. So they had metastatic urothelial carcinoma. They were eligible for platinum, EV, and Pembro, and they were PD-L1 inhibitor naive, had to have GFR greater than 30, got performance status less than 2, and they had 886 patients randomized to EVP or chemotherapy, which was cisplatin-based or carbo plus gemcitabine, maximum 6 cycles, and primary endpoints were progression-free survival or overall survival. And here's the Kaplan-Meier curve that really got them, the standing ovation, because this was huge. The standard in this population would have been chemotherapy, and this was the first time an agent was shown to have an improved overall progression-free survival over chemotherapy. And these Kaplan-Meier curves are, widely different. You can see the EV Pembro at 12 months, 50% of patients were progression-free versus the chemotherapy was 21. And that's pretty durable. So if you get that far out, you see these curves flatten out. So this was really, quite exciting. Keep in mind, this is in the metastatic setting. There's ongoing trials in the neoadjuvant setting right now where we have a neoadjuvant trial open here where patients are being randomized to EV Pembro versus cisplatin-based chemotherapy in the neoadjuvant setting for patients with muscle-invasive bladder cancer. These were all patients that had metastatic disease. This was a huge response seen in patients with metastatic disease. This was really big. So what about some of the subgroup analyses? This is the figure from their abstract. So keep in mind that this has not been published yet. So this is undergoing peer review right now. So this was the data that was published or presented at ESMO. It has made it to the guidelines, however, because it was such a huge response. So it can be found in the NCCN guidelines, and a lot of medical oncologists are using it for patients with metastatic disease. So all the subgroups, so age, sex, performance status, everything pretty much you can think of, liver metastasis favored the EV Pembro. You can see the on this forest plot. What about side effects, right? Because that's something that I've been harping on for all these drugs. We need to know some of the side effects. So serious side effects, treatment related, if you look on this right side of the screen, 27% EV Pembro, 19% for chemotherapy. And overall, not a huge difference between the two groups. So, grade three events were 56% EVP and 70% chemo. So I'd say, not huge differences, but a little bit better tolerated in the EV Pembro group than the chemotherapy group. So at the same time as the EV Pembro trial was ongoing, there was this trial, which, actually beat them to publication. It was the nivolumab plus gemcitabine cisplatin trial. It was a phase 3 trial, similar to the previous trial, the Keynote trial, patients with unresectable or metastatic bladder cancer. They received nivolumab plus gemcis every 3 weeks for up to 6 cycles, and then they would go on to have maintenance nivolumab for up to 2 years. And the comparison group was gemcitabine cisplatin for 6 cycles. And this also was a positive trial. So this is the nivolumab plus gemcisplatin arm. So this is adding the PD-L1 drug to standard chemotherapy. So the addition of that was beneficial. The median overall survival for the Nivo group was 21.7 months versus the GemCis of 18.9 months, hazard ratio of 0.78. So another positive trial showing a new drug that could benefit patients with metastatic bladder cancer. Adverse event rate, so any adverse event, any grade, almost every patient will have some sort of adverse event, but the grade greater than 3s, we saw about 61% in the nivolumab group and then 51% in the Gem-Cis group. So certainly adding the nivolumab does seem to add to the side effect profile, as you might expect. So this was another drug, also on a phase 3 trial, a drug called erdafitinib, and similar patient group, so unresectable or metastatic bladder cancer. The key with erdafitinib that you need to be aware of is they have to have an FGFR2 or 3 alteration. So the patients have to have a biopsy of one of their sites of disease, and then it gets sent to the lab, and they have to see this alteration to be eligible, because this drug targets the FGFR2 alteration. And this was also studied in patients that progressed after immunotherapy, and patients were randomized to erdafitinib or the investigator's choice of chemotherapy. And this has been published in New England Journal of Medicine last year. And keep in mind, only about 20 to 25% of patients have the FGFR alteration. So this drug is a little bit less useful, I think, because you have to have the alteration to receive it and to benefit. But patients that did have the alteration, if they have it, did have a clear benefit over investigator's choice chemotherapy. Once again, I'm showing a lot of Kaplan-Meier curves today, but you can see these curves clearly separate. The erdafitinib arm showed a median survival of 12 months, overall survival of 12 months versus 7.8 months in the chemotherapy group. So almost double the survival in the erdafitinib group. Now, there is a very unique side effect that you need to be aware of with erdafitinib, and that is hyperphosphatemia. So these patients oftentimes need to be on phosphate binders because almost all of them will have some level of hyperphosphatemia. They also need to have eye exams because they can have some issues with their inner eye. All right, I think this is the last drug I have to talk about. But this is also an exciting one. It's called sacituzumab. It just kind of rolls off the tongue. But this is hot off the press, this was just published, I think, last week. So this is the Trophy U01 Cohort 2 study. It was a phase 2 study in patients that were cisplatin ineligible, and they had progressed after prior checkpoint inhibitors. So they had received nivolumab, pembrolizumab, one of the checkpoint inhibitors. And what this drug is it's a TROP2 directed antibody drug conjugate with this interesting payload that the payload is a metabolite of irinotecan. Irinotecan was a drug that had been given for many years for a variety of cancers, but it was pretty toxic. So by giving it in this fashion, they can target the cancer cells more directly. TROP2 is highly expressed on bladder cancer cells. So it was really a unique, I would say, mechanism. And irinotecan is a topoisomerase 1 inhibitor. That's how that works. So it gets the drug directly where it needs to go, with hopefully lessen some of the side effect profile. So this is our waterfall plot for these patients. So it was 58 patients in the cohort, but it did show that you've got a lot of patients, if they fall below here, that's the percent change from baseline. That means they're having a response. So the vast majority of patients are having a response. These blue ones are partial responses. But we're seeing, this is based on RECIST criteria. So looking at the response to the tumor under imaging. So we're seeing a response. Now the spider plot here shows also a different way of looking at responders versus non-responders. So once again, if you fall in this category and it's showing the percent change from baseline, you're seeing a response. So we're seeing quite a few responses once again. And then our swimmer's plot here looks at, once again, patients showing responses over time. And we see ongoing responses going out, months. So this essentially shows, with this targeted therapy in patients that were heavily pretreated, you're still able to get a response. So this is kind of the new kid on the block, sacituzumab. And I think if, it's sort of our last ditch resort right now, but we are seeing responses in patients that were heavily pretreated, that had very resistant disease. And I think it'll be interesting to see where this will fall into the sort of algorithm in the future, and what the role will play. The key to note from treatment-related adverse effects for this is this one tends to be very cytotoxic. So patients need to be supported with GM-CSF to help build up their cell counts. A lot of these patients will get neutropenic and anemic. All right, so take homes for what's hot. So certainly immunotherapy. We talked about the use of nivolumab in addition to chemotherapy, and then the targeted therapy, right? The enfortumab vedotin, as well as the pembrolizumab, is definitely really exciting time to have these new agents. 10 years ago, all we had was really cisplatin-based chemotherapy, and now we've got all these new drugs that are showing a good amount of activity in these patients. And then just be aware, once again, of some of the common side effects of these agents. So in conclusion, we have right on time, thankfully. Multimodal therapy. I hope I've convinced you that it's really imperative for patients that have muscle-invasive bladder cancer, whether you give it neoadjuvant or the adjuvant setting. It's something that we need to talk to our patients about, and via shared decision-making, I think, come to an acceptable approach for each individual. Neoadjuvant therapy is still considered the standard for patients with muscle-invasive bladder cancer. But adjuvant therapy, there's some newer drugs emerging in that space as well. And then there's some really new and exciting immunotherapy and targeted therapies, the sacituzumab, the EV-pembro data. I think it's really an exciting time for our patients. And I'm happy to answer any questions. Thank you very much. Yes, Dr. Abel. Yes, yeah. So it's a phase 3 clinical trial. It's run out of the cancer center. I believe the medical oncologists are primary on that trial, and patients are being, with muscle-invasive bladder cancer, localized disease, are being randomized to EV-pembro in the neoadjuvant setting versus gemcitabine and cisplatin. And then they go on to, once they complete neoadjuvant chemo or immunotherapy, go on to cystectomy. And then they get followed closely, and we're looking at, I'm not sure what the primary endpoint is. I think it's probably recurrence-free survival. Yeah, it's a nationwide phase 3 trial. There's several other trials in this neoadjuvant space with EV-pembro that are ongoing. So it's kind of a little bit of a race to see who gets there first. And it's still open and accruing, I believe. Is that the same phase 1? Yeah, I think for this trial, they are inclusion criteria are PT2 to 4, so they can have more locally advanced disease. And I believe N1 is also acceptable. So if they have one lymph node in the true pelvis that's suspicious for disease, they could be considered for the trial. But I think your point is good. There are certainly some, patients that have just sort of your, standard muscle invasive disease, and then there's patients that have more locally advanced disease. I think outside of a trial, I tend to push a little bit more for neoadjuvant chemotherapy in patients with more, locally advanced disease, because I think those are the patients that probably benefit the most. Versus if you have like an 82-year-old with T2 disease that's not a huge bulky tumor, I think that's somebody I might not push as hard towards chemotherapy. Seeing patients that have kidney growth, that kind of lots of
some of these patients have as we've been operating on have everything that's
Yeah, I mean, I've certainly done a few, I would say, I was going to say salvage. They're not really salvage, but cystectomies, for patients with bulky disease that have received EV pembro. And it depends. I mean, sometimes it's a disaster. Betsy and I were just talking about a case that she had in fellowship where they had EV pembro, and you kind of chisel it out. I don't know if that's from the chemo or the immunotherapy, or if it's just from the disease itself, right? Because a lot of these patients just have bad disease that's really inflamed anyways. It's hard to say. But I do think it's a new era. Like I think when we have these types of drugs that can help salvage some of these patients, I feel like, I see a patient that has something that is unresectable. I tell them there's hope. Like we can, in the chemotherapy era, I'd say, I don't know about this, but with the EV pembro data and the responses that we've been seeing, I think there's a real, we certainly have cases where patients were initially unresectable and they get EV pembro, and now we can take out their bladders.
Yeah, really great stand-in talk. I'd say you almost did better than the medical oncologists.
Stayed on time.
Stayed on time and much more pertinent, perhaps. Yeah, it's just striking how finally we're seeing the field of advanced bladder cancer move forward. And just had a question about sort of personalized medicine. You mentioned sort of FGF receptor, and I know Josh Meeks has done a lot of work looking at sort of predictors of sort of immune-based treatments. Are we routinely at that point where sending tissues off to be analyzed and then putting patients into these various treatments yet, or how far away are we from that?
Yeah, I think it's imperative that we, especially patients with more advanced disease, that we do send off their tissue for foundation testing and look for mutations that are potentially targetable. But I think the problem with bladder cancer is there's, at least the ones that I've sent off, is there's not anything actionable in the vast majority of these patients. That being said, the best data is for the erdafitinib. If you have that FGFR alteration in the 2 or 3 receptor, those patients clearly would benefit from that agent. TROP2 is highly expressed on almost all bladder cancer cells, and then the PD-L1 pathway testing for sort of percent expression hasn't really borne out. So I think outside of erdafitinib right now, I think that's probably your best bet, because we actually have a drug that can target that. But I think that's the future, hopefully.
I just have a question. Now that we are seeing more or better responses with some of our neoadjuvant therapies and things, do you think there will ever be a role for bladder sparing, where if we survey these patients after they get neoadjuvant therapy, maybe you do a complete TURBT, they've got no residual disease, do you think that there will be a role for just monitoring their bladder rather than proceeding with radical surgery?
I hope so. Yeah, I hope to do fewer cystectomies, because I think I tell patients, there's I can't make you anything as good as the bladder you were born with. So as long as their bladder is functioning properly, I think they'd much rather retain their own bladder. And I know some of the trials, there's an option to retain the bladder at the end of, once they finish neoadjuvant therapy. That's part of many of these trials. So I'd say right now that's experimental, but I'm optimistic that we can, through these clinical studies, figure out which patients it's safe to do that in. Because right now we just don't know, what's going to happen if you leave the bladder in. Will they recur? How quickly? Because I think the 38% of patients that are T0, a certain percentage of those probably could have kept their bladder, and maybe they would have never recurred. We just don't know. But I'm hopeful that we will be able to take out fewer bladders in the future. I'm starting to get kind of tired, so. No.
All right, terrific. Thank you, Kyle. Very exciting area and domain of urologic oncology, and look forward to hearing updates from you in the future. Let's shift gears and maybe just take a few minutes to move over to indications. How about 7:55? We'll kick that off.